Good morning, everyone, and thank you for very nice introduction. Today, my topic is STI treatment and prevention. And this is outline for my topic. I will touch a bit about STI situation, and then I will go through management of urethral discharge, which include gonorrhea treatment guideline and also about novel gonorrhea treatment, and including gonococcal surveillance data in Thailand. And I will move forward to alternative treatment when benzathine penicillin G is shortage. And lastly will be about STI prevention. So as you know that there is an increasing trend of STI in worldwide, especially in many parts of the world, including high-income countries like US and European countries. In this slide, show you STI situation in Thailand, which is similar to the global STI situation. The data comes from 506 report, which is voluntarily reported from public sector. On your right-hand side, you will see that STI is more common in male more than female, and high prevalence in patients among 15 to 24 years old. In this graph on your left-hand side, you will see that the blue line represents syphilis. Syphilis is increasing since 2014, and until now, this is an increase around 6 times over the past 10 years. On the red line and green line, you will see that those are gonorrhea and non-gonococcal urethritis. With limited resources, in Thailand, we still rely more on syndromic approach than etiological diagnosis. So our report comes from the data that have syndromic diagnosis rather than etiological diagnosis. I will touch a bit about STI syndrome. Syndromic management of STI include the identifications of the syndrome on the basis of patient's symptoms and signs. So when you see patient come with genital ulcer, you may think about syphilis, you may think of herpes, and nowadays you should not miss mpox also. However, for syphilis, you have point of care test to diagnose, differential from herpes and mpox. But for urethral discharge, vaginal discharge, and its complications like scrotal swelling and lower abdominal pain, it is quite challenging to low and middle income country to get the diagnosis with the etiological pathogens like gonorrhea and chlamydia. In Thailand, we just announced the latest STI management guideline last year. In this guideline, we recommend to manage urethritis cases based on available laboratory testing in the services. So if you are in the system that do not have any lab facility, so just have take history, sexual risk assessment, do physical examination, and provide empirical treatment. But if you are in the setting that have laboratory support, such as molecular assays or culture, so please shift to etiological diagnosis. However, if etiological diagnosis by using laboratory cannot give you the result within one day, so please treat your patients as syndromic treatment before you get the diagnosis. So the reason that we try to shift the from syndromic treatment to be etiological treatment, because right now we are facing with antimicrobial resistance, especially Neisseria gonorrhea. WHO update list of drug-resistant bacteria most threatening to human health, and Neisseria gonorrhea classified as a high priority list. Neisseria gonorrhea has developed or acquired resistance to all antimicrobial introduced for empirical first-line treatment of gonorrhea. The only remaining effective option for empirical first-line monotherapy is the third generation extended spectrum cephalosporin that you right now use as ceftriaxone. However, in 2018, there is the first case of STI strain isolated in UK and Australia. Patients gave some history that traveling to Southeast Asia, and of course, one country is Thailand. So right now, I would like to compare our latest guideline with the European guideline and also CDC guideline and WHO recommendations. For European guideline, they recommend to use ceftriaxone 1 gram plus azithromycin 2 gram. And if they are in the good surveillance place or test of cure is possible, so they can use only ceftriaxone 1 gram. For US, standard treatment is ceftriaxone 500 milligram, but if patient weighs more than or equal 150 kilogram, they can up dose to be 1 gram. For the WHO guideline last year, they up dose from ceftriaxone 250 milligram to be 1 gram intramuscular. But if ceftriaxone is not available or and test of cure is not possible, so they suggest to use two medication of oral antibiotic, that is cefixime 800 mg orally plus azithromycin 2 gram. For Thailand, we suggest to use ceftriaxone 1 gram as our surveillance data show that we have the increasing trend of MIC that I will present shortly. And we recommend to treat chlamydia as because of many parts of the country, we cannot test chlamydia and then chlamydia trachomatis testing by using doxycycline should be in a common practice. But if ceftriaxone is not available or possible, cefixime 800 mg orally plus azithromycin 2 gram should be prescribed. So right now, we are facing to the maximum dose of treating Neisseria gonorrhea, that is 1 gram. Experts say that 1 gram and 2 gram is not different in treating for gonorrhea. So after we announced our guideline, shortly, we saw the alarming case report. This case that I would like to show you is just 15-year-old Thai male, no underlying disease, present with urethral discharge for 1 day, and he went to pharmacy, and pharmacist gave him cefixime 800 milligram and azithromycin 2 grams. So our pharmacist is quite updated to the guideline. And then 1 week later, after receiving treatment, he did not get better and back to the same pharmacy again and received the same treatment with oral antibiotic. And because of the symptoms did not go away, so he went to a hospital in Thailand. And from the testing, we found that gram stain showed gram-negative intracellular dipococci. During waiting for cultural result, the treatment is ceftriaxone 1 gram plus doxycycline 200 milligram per day for 7 days. And the cultural result come back with Neisseria gonorrhea, which antibiotic susceptibility test show resistance to cefixime and high resistance to azithromycin. This is the reason that's why he did not get better with the 2 oral medications. So is this a time that should we stop pharmacy prescribe oral antibiotic to the patient in Thailand for Neisseria gonorrhea? I don't know. Is this possible? Yeah. So right now, I think that we are currently facing resistance to cephalosporin, which represent the last line treatment option for gonorrhea in Thailand. I would like to show you gonococcal antimicrobial surveillance program, which we conduct here with gathering the data from STI clinic in each part of the countries. And this slide shows you the percentage of Neisseria gonorrhea isolate resistant to ceftriaxone, cefixime, azithromycin in Thailand during 2012 till 2024. The total number of isolates are around 6,800 isolates. This shows that we have been noticed azithromycin resistance since 2016, and in between 2021 to 2022, it showed that we have a six-fold increasing of azithromycin resistant. We have been notified for Symposium resistance in 2022, but we have not seen any cases that found ceftriaxone resistant while using the LSI criteria. But 3 isolate in 2023 meet UCAS cutoff and show ceftriaxone resistant with MIC 0.25. I think that this time Thailand have to thinking about using antibiotic stewardship and also strengthen surveillance program, which can improve the early diagnosis and treatment of patients and their sexual contact. And this is a global data about the surveillance report in 2023, which includes 9 countries, such as Thailand, Indonesia, Vietnam, Cambodia, Philippines, South Africa, Malawi, Uganda, and Zimbabwe. So the data show the high prevalence of gonorrhea and also antibiotic resistant rates are alarming. The results show that in Cambodia, 9% of samples were resistant to all 3 primary antibiotics tested, such as ceftriaxone, cefixime, and azithromycin. In Vietnam, 20% of samples show resistance to ceftriaxone. However, Thailand and South Africa still show the low level of azithromycin resistance that were detected. But from the case that I just told you recently, so this is the thing that just behind the iceberg, below the iceberg. By the way, we need to think about ceftriaxone resistance also, that those strains that are linked with pen A60 and pen A34 that right now are spreading internationally. Could we go back and use the old drug like gentamicin, spectinomycin as an alternative treatment for gonorrhea? Let's see. Gentamicin has been considered a promising option for the treatment of gonorrhea, especially in dual therapy. This aminoglycoside has been used in some African countries since 1993, and it is a first-line treatment in Malawi, where cure rates are greater than 95%. This report in 2010 and 2011. However, in 2022, there is a publication about treatment outcome of urogenital gonorrhea after 25 years of sustained gentamicin use in Malawi. In clinical part, it is found that 183 Neisseria gonorrhea culture positive men enrolled, and 82% has come with test of cure. They found that 10% had a positive culture at test of cure. Let's see the laboratory result. There are 141 baseline isolates were tested for gentamicin susceptibility using e-test. They used a cut point that gentamicin resistance is equal or more than 32 microgram per ml. And if gentamicin resistant MIC is equal to 4 microgram per ml, it means that susceptible. But when you compare with the positive culture at test of cure, that means resistant to gentamicin in clinical part, and compare with the laboratory result, the number of laboratory results is not correlate with the clinical part at all. They don't show anything that resistant to gentamicin for the MIC, but clinical part is 10% resistant. So gentamicin MIC poorly predict gonorrhea treatment outcome with gentamicin treatment. So if you use gentamicin to treat and having the surveillance system, you cannot correlate for the MIC and clinical outcome. For spectinomycin, right now, the resistance to spectinomycin is quite rare worldwide, and some countries use this antibiotic for the therapeutic treatment failure. In Thailand, we don't have spectinomycin in our country. And If you use spectinomycin, please aware that the efficacy of spectinomycin in the treatment of pharyngeal gonorrhea is quite low, only 51%. So this is, if you use, you may have to check for all anatomical sites, including oral and rectal, before. If it's clear from gonorrhea, so spectinomycin may work for gonococcal urethritis. So right now we are moving to see the novel treatment for gonorrhea. There are two medications, that is soliflodacin and gepotidacin, that just finished phase 3 study in 2023. For soliflodacin, mechanism of action inhibits topoisomerase 2, and gepotidacin inhibits topoisomerase 4 and the B subunit of DNA gyrase. In clinical trial phase 3, soliflodacin 3 gram single dose orally was not inferior to ceftriaxone 500 mg plus azithromycin 1 gram in uncomplicated gonorrhea. And their side effect is quite low and they do not have any serious side effect. For gepotidacin, in clinical trial phase 3, gepotidacin is 2 doses of 3 gram. So it means that patient need to take antibiotic 12 hours apart with 2 doses. And this is oral antibiotic. The results show that gepotidacin was not inferior to ceftriaxone 500 mg plus azithromycin 1 gram in uncomplicated gonorrhea also. However, the side effect is mild to moderate GI effect was found. 62% experience diarrhea, 31% have abdominal discomfort. Is it possible to use soliflodacin and gepotidacin in Thailand? Any data support on that? So in this publication show the genomic surveillance and antimicrobial resistance in Neisseria gonorrhea in 2018 with using Bangkok isolates. We found that 100% susceptibility for soliflodacin, and the result of whole genome sequence, we do not see any strain that contain gyrase B mutations that associated with increased MIC of soliflodacin. And also, we do not see any mutations associated with gyrase A, which relate to gepotidacin also. So in 2018, we found that it's quite good for 2 medications if we can use in Thailand. However, we found from the sequencing that 47% of the isolates had a PARC D86N mutation, which may predispose for gepotidacin resistance. So despite the promising news of 2 new antibiotics, the potential for resistance to these treatments remain uncertain. This highlights the urgent need to prioritize antibiotic stewardship to preserve their effectiveness as long as possible. Let's move to syphilis. The WHO estimated that more than 6 million annual doses of 2.4 million units of benzathine penicillin G are required to treat adult syphilis. And you may have heard about benzathine penicillin shortage in many parts of the world. Between 2014 and 2016, at least 39 countries reported benzathine penicillin G shortage, resulting in patients receiving non-recommended therapies. How can we select alternative medication? Please note that the search for alternative treatment for syphilis seeks to address situations where penicillin cannot be used, such as when there is shortage of antibiotic or when the patient is allergic. When we look at the existing agents like azithromycin, ceftriaxone, doxycycline, I will show you the data shortly if we select those medicine. And also, we also have a medicine that in the trial, like novel agents such as cefixime and lysolis also. This is the data of syphilis treatment in systematic review and meta-analysis. It includes 27 studies evaluating alternative drug strategy for non-neurological syphilis instead of penicillin. Alternative drug approach including ceftriaxone, azithromycin, and doxycycline monotherapies. This demonstrates that its equivalent serological cure rate to benzathine penicillin G in non-neurological syphilis, even among HIV-positive patients. So let's move one by one. For benzathine penicillin G and doxycycline, there is no randomized control trial. Many non-randomized observational studies have shown its effectiveness against syphilis. So experts often recommend this as a second-line treatment. However, this is limited evidence on its effectiveness for neurosyphilis, and it cannot be used during pregnancy or in children. When comparing benzathine penicillin G and azithromycin, early trials show the efficacy of azithromycin against syphilis. However, there are some concerns regarding the use of azithromycin as a second-line drug for syphilis treatment due to high prevalence of E. coli resistance reported in various parts of the world. And you will see that nowadays we use more and more ceftriaxone in the case that cannot use benzathine penicillin G. Ceftriaxone have shown efficacy similar to benzathine penicillin G in treating early syphilis. However, there is limited evidence for its effectiveness in neurosyphilis, and it requires a prolonged course of intramuscular or intravenous administration, which could lead to issues with the treatment compliance. So right now, we still find the best one that comes instead of benzathine penicillin G, but each antibiotic will have a weak point and strong point in different ways. And I move to my last part, that is STI prevention. So I start with A, B, C. A can be abstinence, that is abstain from sex, and be faithful. C means using condoms, and A, to get tested, or some people say delay sexual activity, and maybe some have some more letter like E, education yourself. Today, I would like to introduce one more C and one more D. Okay, so let's go to another C, circumcision. We talk a lot with circumcision to prevent HIV, but not many people discuss about circumcision can prevent STI. So this is a publication to show you the circumcision can prevent both HIV and some STI in men who have sex with men in systematic review and meta-analysis. 62 observational studies, including 119,000 MSM circumcision, was associated with 23% reduced odds of HIV infection among MSM, and also found that circumcision was associated with reduced odds of herpes simplex virus infection among MSM overall, and benign human papilloma virus infection among HIV-infected MSM. So I hope that now you got another C in your mind. And then another D that I would like to propose today, that is biomedical STI prevention, which is DoxyPEP. Yesterday, we talked a lot about DoxyPEP by Dr. Patria, so I do not go to detail for all of that, but I just would like to remark you that the last three large studies show the reduction in incidence of chlamydia and syphilis were observed, but less reduction in incidence of gonorrhea. And many experts concerned about the emergence of doxycycline and tetracycline resistance in STI pathogens and resistance selection in non-STI pathogens and commensals also. In Thailand, we published the interim guidance for the physician that would like to use doxycycline as doxy post-exposure prophylaxis. And we state that doxycycline post-exposure prophylaxis may not prevent gonorrhea for Thai people. This is the data from Bangkok STI Center to show you that 90% of the isolate already resist to tetracycline. And you will see that MIC that more than 1 microgram per ml, which is on your right side. This is already 90% of all isolate that we found in 2018 to 2022. And when we see the MIC50, it is around 8 to 6, which is a high resistance for tetracycline resistant Neisseria gonorrhea. And MIC90 shows 16 to 30 microgram per ml. So we already have the high resistant isolate to tetracycline. For my last slide, I just would like to summarize for the STI vaccination development to prevent STI. We already seen hepatitis B vaccine, hepatitis A vaccine, and we just talking about HPV vaccination. And recently we see the mpox vaccination. Those are already in phase 3 study. But for gonorrhea, still in the phase 3 trial. And we hope that we will see herpes simplex vaccine move to phase 3 soon. However, chlamydia, syphilis, and trichomonas still in the phase 1 and preclinical. With the situation that we face with antimicrobial resistance for STI, we hope that we can have STI vaccination and update STI vaccination the same as moving forward to HIV vaccination soon. Thank you very much. This is my last pass, the conclusion. The global burden STI need prompt treatment for STI is important to reduce the risk of both acquisition and transmission of HIV. Drug-resistant gonorrhea is an urgent public health issue. The exceedingly high level of gonococcal tetracycline resistant doxypep will unlikely significantly reduce the gonorrhea case in Thailand. And new preventive and therapeutic technologies and knowledge are necessary to be utilized to break the chain of STI transmission. Thank you. And if you have any question, please feel free.